Hello and welcome to today's webinar entitled Ensuring Its Value, Validated Cost Effectiveness of Medtronic Reveal LINQ, New Guidance from UK's NICE Diagnostic Assessment Program for Cryptogenic Stroke. My name is Alex Tarantino. I'm a Market Development Manager for Medtronic Diagnostics, and I'm delighted to be joined today by Dr. Klaus Witte, Senior Lecturer and Consultant in Cardiology at University of Leeds in the UK.
Hey Alex, nice to be here.
Dr. Matthew Reynolds, Electrophysiologist at Leahy Hospital and Medical Center in the US.
Hi, thanks for having me.
And Dr. Paul Guyler, Consultant Stroke Physician at Southend Hospital in the UK.
Hi Alex, thanks for having me.
Today's session is brought to you by Radcliffe Cardiology and is supported by Medtronic. I'd like to remind you that today's session is interactive. So should you have any questions you'd like to put to the faculty, please submit them in the form on the webpage, and we'll address as many as possible towards the end of this webinar. I'd also like to remind you that today's session is CPD accredited, so to claim your CPD points, please follow the instructions provided at the end of this session. In addition, we encourage you to complete the feedback form that will display on the webpage in the latter part of today's event. I'd now like to hand it over to Dr. Reynolds to review the learning objectives for today's session.
Okay, well, as Alex, I think mentioned briefly, what we're here to talk about specifically are insertable cardiac monitors, specifically Medtronic's LINQ monitor, in the context of health economics and cost effectiveness. So the learning objectives for the hour are first how to think about cost effectiveness generally, broadly. I'll be speaking to that for a few minutes. And then how to think about cost effectiveness specifically in the context of the UK NICE program. The LINQ device is a diagnostic tool, so it's been evaluated through the NICE Diagnostic Assessment Program. So my colleague Klaus Witte will be speaking about that a little bit. And we'll try to help you understand how does NICE decide if a medical technology is cost effective. And we'll go into a little bit of detail specifically about the Reveal LINQ. So what evidence led to the conclusion that this clinical strategy using this technology is cost effective, specifically in cryptogenic stroke. So that's the clinical scenario that's under discussion today. Is cryptogenic stroke. And then we've pleased to have our colleague Paul, who's going to talk about how he's incorporated this into his stroke practice and try to help you understand how you may be able to incorporate it into your own. So let me begin with just the background. We'll begin broadly talking about cost effectiveness in general. So conceptually, what does it mean to say that a medical technology or a clinical strategy is cost effective? This is a common way to understand. One way of saying this is value for money. I like to use the investment notion of return on investment. So in healthcare, we spend money and we want to know, what are we getting in return for the spend? Are we getting a lot back in return? Are we getting a little back in return? And ultimately, what is the ratio? What is the balance between what we spend and what do we get back? So one way Michael Porter's value in healthcare concept describes this as value being defined as the health outcomes achieved per dollar spent. When we conduct cost effectiveness studies, which I've done many times for a number of different cardiovascular technologies, there's several things that have to be measured. It's really a limited number. Although these analyses can be quite complex, all such analyses have boiled down to essentially three variables, one of which is provided ahead of time, and that is the so-called willingness to pay threshold. So to the right of this slide, I'm going to show you essentially what is measured in all cost effectiveness analyses. And I think the first thing to understand is that this is always a comparative exercise. We're always comparing some new technology, some new clinical strategy to some existing status quo or existing standard of care. So in the figure to the right, that status quo is graphically represented by the origin, the 0, point, on what we frequently refer to as the cost effectiveness plane. So that one of the first variables we have to know is the willingness to pay threshold, or what cost effectiveness threshold is considered acceptable or not acceptable. And the easy thing for researchers is that that is provided. That is one of the three things so we're already a third of the way done. See how easy that was? So the willingness to pay threshold is very context dependent. It depends on the healthcare system that's under discussion. So for today, we're talking UK NICE, but every health system, every country, has its own approach to this. Once we then move on to actual measurement, we have two things that we have to sort out. We have to measure incremental effectiveness. So in this version of the cost effectiveness of plane, incremental effectiveness is on the x-axis. As you move from left to right, you're increasing effectiveness. Usually those measures of effectiveness are coming from clinical trials or some other form of clinical research. And then the other parameter that has to be known is the incremental cost. So again, this is compared to some status quo, some standard of care. What is our new treatment or our new treatment paradigm? How far is it moving us to the right in terms of incremental effectiveness? And how far is it moving us up? Usually up, maybe down if it's saving money, that happens sometimes, but most of the time moving up in terms of incremental costs. And once we know those two parameters, the outcomes achieved and the money spent, then we can estimate a point in this cost effectiveness plane, so the black circle. If, as is usually the case, incremental effectiveness is being measured in life years or quality adjusted life years, and a little bit later in the hour, the concept of the quality adjusted life year will be discussed, then we can actually make a ratio of those quantities. We can take the incremental costs and simply divide it by the incremental life years or incremental quality adjusted life years to generate a ratio, a numerical ratio, a single number that summarizes cost effectiveness. And that's referred to as the incremental cost effectiveness ratio, or ICER. And once we've made that estimate, then we compare it to our willingness to pay threshold, which again in this figure is represented by the diagonal dashed line, where everything to the right and below of that line would be below the willingness to pay threshold, and we would therefore conclude that's a strategy that is cost effective. Whereas any points above or to the left of that line, we might assume or we might conclude that that strategy is not cost effective given the parameters that we studied. So what do we know about the cost effectiveness of insertable cardiac monitors for cryptogenic stroke? Well, we can look to the academic literature, and Dr. Witte and I have contributed to this. At this point, there's one published manuscript, peer-reviewed manuscript, specifically using data related to the LINQ device for patients with cryptogenic stroke. This was a paper that we published in 2016. It was done from a UK perspective. And we did, in fact, conclude that the LINQ was cost-effective for this clinical indication. In addition to that manuscript, there have been 3 abstracts presented at national and international meetings that have explored the same question in different country contexts: Australia, Canada, and most recently the United States. We've got a manuscript that is in peer review for the US model. But the findings of each of these studies have been quite consistent Again, Klaus is going to walk you through some of the clinical evidence that led us to those conclusions. But the conclusions consistently were that the LINQ insertable cardiac monitor is indeed cost effective, meaning good value for money for patients with cryptogenic stroke. At this point, I am going to hand it over to my colleague Klaus to review, again, some more specific background about the diagnostic assessment program from UK NICE and some of the clinical evidence that underpins our previous assessments and their assessments of the cost effectiveness of this technology.
Well, thank you very much, Matt, for that excellent introduction. The National Institute of Health and Care Excellence is essentially a HTA body that explores the utility of new therapies and new diagnostic tools, both in terms of their clinical efficacy and in terms of their cost. And so there you go, you have the two basic issues that we have to explore whenever we as physicians or healthcare professionals decide on what might be the best for either an individual or more frequently a population of patients. We have to know that the device does what it says it should do, or the treatment is as effective as we think. But we also have to know about the cost of this device or this treatment in order to allow us to make sensible healthcare decisions on behalf of our population and indeed the individuals we care for. So the health technology assessment involves a systematic evaluation of the evidence of a health technology. It usually doesn't focus on a single item. It usually focuses on a class, and that class can be either a drug or a device. And as a once the HTA assessment has concluded, it usually informs reimbursement decisions. Now, the National Institute for Health and Care Excellence is one of the most highly regarded HTA bodies in the world. Its outputs are eagerly awaited by companies and healthcare providers, payers, and governments alike. And they often adopt the advice of NICE rather than doing their own assessment, because as Matt has explained, these can be a little bit complex, or at least the advice and guidelines that they produce are influenced by the NICE body in the UK. So what is the diagnostic assessment program? Well, this is a specific HTA program that looks at innovative or diagnostic technology, and it does include cost effectiveness analysis in its assessment. The challenge sometimes is that when we go through this program with a diagnostic tool, we don't always have clinical outputs that we can use to plug into the calculation that Matt has just explained for you. So the modeling that needs to be done often is a little bit more complex and involves exploration of the responses to a positive or a negative finding on the diagnostic tool and how that might then play out in terms of outcomes. And the final output of a DAP, diagnostic assessment program, is often a guidance rather than being associated with mandatory funding decisions, certainly in the UK, but it does provide high quality objective evidence that allows regional and local payers to make decisions about how they might run their pathways. On the whole, however, if the technology is recommended, payers are usually encouraged to accept that this should be incorporated into pathways and that they should fund the process. So let's have a look at briefly what led to the conclusions made by NICE. What they did in the DAP, they looked at the standard of care for patients with cryptogenic stroke, and they looked at how that might be affected by the use of the Reveal LINQ insertable cardiac monitor. And largely that was based around assessing What happens if you have atrial fibrillation discovered following a cryptogenic stroke? What is the treatment that you might receive? And how effective is that treatment, both in terms of preventing strokes, but also in terms of the risks of causing bleeding? And that is, of course, a part of the package that people accept when they take anticoagulation therapy. So that had to be included in the model. The model also, of course, has to include a large proportion of patients who, despite having atrial fibrillation, will not have a stroke or don't have a stroke. So the model has to include all of these variables, and these data were taken from published data sets over the last 10 years, assisted greatly, of course, by some of the anticoagulation papers that have come out with the release of the DOACs over the last 10 years. So they modeled the degree of stroke, the severity of the stroke, the frequency of the stroke, the complications of the stroke, and allowed thereby the calculation of the quality of life assessment of patients who have had a cryptogenic stroke and then go on to have or not have a second cryptogenic stroke. NICE were guided largely by the results of a study that I think most people have heard of and know of in quite detail, because it really did change the world for many people dealing with patients with cryptogenic stroke. But their eventual assessment came out that they calculated that if you anticoagulated patients appropriately who have atrial fibrillation discovered following a cryptogenic stroke, you would avoid 52 strokes per 1,000 cryptogenic stroke patients. Now, to go back to Matt's discussion around cost effectiveness, we have to first of all establish that the treatment is clinically effective. And so the modeling that the NICE DAP showed suggested that this diagnostic tool was clinically effective. So the question of cost effectiveness is this now something that is valuable to the population? What is the cost of avoiding these 52 strokes? In general, in the UK, we tend to work on a willingness to pay threshold of around £20,000. That tends to vary a little bit depending on the profile of the condition that we're dealing with. But in general, £20,000 for a quality of life adjusted year. In other words, a year of high quality life. That may mean 2 years of half quality life, or 6 months, or let's say 3 years of third quality of life. So if you get 3 years at 30% quality, that is a full year of quality of life. So the Crystal AF study, that I mentioned before, really did change a lot of people's opinions and has changed a lot of pathways for these patients. It was basically a randomized controlled trial of 441 patients who had been admitted with a cryptogenic stroke. The diagnosis was made, as frequently is already done, based on imaging of carotid arteries, echocardiography, and brain scans in order to determine that these were indeed patients with cryptogenic stroke. Patients were then randomized to either receiving an implantable loop recorder or standard of care, which involved a variable amount of Holter monitoring depending on local practice. The graph is, of course, quite impressive. After 3 years, 30% of patients with the loop recorder had atrial fibrillation diagnosed. This is a stunning figure when you compare that only 3% of those patients in the standard care arm were diagnosed with atrial fibrillation. And so this is the basis of the clinical efficacy that NICE used. They determined that if patients diagnosed with atrial fibrillation were treated with anticoagulation, you would prevent a certain number of recurrent strokes, as I've described. Of course, some of those strokes will lead to disability, some of them will lead to death, and some of them will have no clinical relevance at all in terms of the quality of life of the patient. All of this can be modeled based on observational data sets collected over the last 10 years. As I've described, there are, of course, also disadvantages from anticoagulation, and these can be put into the model as well to allow a true estimate of what would happen in a normal, everyday, real-life population. So the key results of the assessment are, as you will suspect, hinted at by Matt and myself previously. LINQ is absolutely recommended based on the NICE assessment in patients who have had a cryptogenic stroke. They did, I was involved in the discussions, and they did attempt to explore the utility of other offerings. Unfortunately, because of lack of evidence, they were unable to comment on the use of the biomonitor and the ConfirmRx. They determined that it was clinically effective. They determined that LINQ was also cost effective. They also did a sub-analysis using remote monitoring and the FOCUSON program, and they showed that this was also a cost-effective addition to the pathway. So as we've discussed earlier on, the evidence synthesis includes not only clinical effectiveness, but it includes the quality of life year gain and the incremental cost, allowing you to calculate what is known as the incremental cost effectiveness ratio. In other words, what is the uplift in cost over and above standard care? And as Matt has hinted, almost nothing is less expensive as we go forward. Almost everything is more expensive. But how much more expensive and how much more quality of life do we get? You might only get 6 months of full quality of life, but if you can put that into the calculation, you can figure out the incremental cost effectiveness ratio. And NICE's calculation came out at showing that using a reveal link in patients with a cryptogenic stroke who've been investigated according to in the Crystal AF study, which is pretty standard in patients following an embolic stroke. As I've suggested, there was 52 strokes avoided per 1,000 patients, taking into account the upfront cost of the device and the healthcare requirements of the patients subsequent, including the anticoagulation effects. The base case came out at £10,000. If you add in the FOCUSON plus the device monitoring, this is increased slightly, but it's well below the standard for patient care and being cost effective in the UK. And in fact, it's pretty steeply below that of other first and second world healthcare services.
Klaus, if I could interrupt you for a moment to ask a question.
Of course, Matt.
So, as you know, we published in the academic literature an estimate on the cost effectiveness of this same strategy. And I'm always curious to see when I publish a cost effectiveness model, given that they always involve some uncertainty. I'm always curious to see what some independent group reaches, what conclusions are reached by some independent group. And my intuition, my experience is that the independent groups that NICE uses to build their health economic models most often will use very conservative assumptions and often reach conclusions about cost effectiveness that are less favorable than I have in my own work. And I noticed here, so the base case estimate was around £10,000 per QALY gained. That's actually a fair bit lower than what we published several years ago, where we had an estimate that was closer to £17,000 per QALY gain. It seemed like most of the differences had to do with pricing and cost, because the estimates of clinical effectiveness were very similar. But my question for you is, how many times have you seen that? I obviously am an American, so I don't look at all of these NICE reports as frequently as you and your colleagues do. How many times have you seen NICE estimate the cost effectiveness of something to be more favorable than what sponsors come in with, or sponsors working with academic colleagues come in with?
I think that's a great question, Matt, and it's absolutely appropriate that you ask this, because I've also never seen it. As you say, the assessment that the DAP did took place a couple of years after we did ours, so they may have used more up-to-date data around the safety and the effectiveness of some of the newer agents. The cost of care goes up for disability, for example. So there are a number of things that might have changed. But on the whole, you're absolutely right to raise the question. This is almost never seen. In fact, I haven't heard of it, that the assessment done by the sponsor comes out as higher than the assessment done by the independent body.
Well, it's an interesting result, and I think it speaks to the strength of the clinical evidence.
Yeah.
Where I think that their estimate of the QALY gain was within a 1/100th of a QALY of what we obtained in our model.
Yes.
So that part of it was very strong and consistent.
Yes.
Okay, well, I think I'm going to carry on the conversation from here, just to speak for a moment about FOCUSON. FOCUSON, for those of you not familiar with it, is essentially a service provided by Medtronic to help hospitals and clinics manage the flow of data that comes from LINQ devices to the clinical offices. This is done using something called the CareLINQ network. So I'm a cardiac electrophysiologist. My hospital, we have a very large device practice, pacemakers, defibrillators, and we're well resourced. We have a number of dedicated staff to work with remote monitoring for those devices, and we use the CareLINQ network. So you see in the figure that information is flowing from patients to the CareLINQ network, and in the practice model that I work in, that information goes directly from the CareLINQ network to the clinical team at the hospital. You can imagine there may be many smaller hospitals, maybe with lower volume device practices, that don't have the sort of infrastructure that we already have at my center. And so there's a lot of information to be managed. Probably the majority of the downloads from the LINQ devices are going to be normal. But some of them are going to have important information that needs to be acted on quickly. So the FOCUSON program is an optional add-on to help triage and manage the data as it comes in. Routine, normal findings from the devices will be communicated to the hospital clinical teams on a more, perhaps a sort of slower time schedule. In other words, a more regular time schedule, whereas things that are abnormal, atrial fibrillation and other abnormal rhythms detected by the LINQ devices can be sent as notifications to the clinics much more quickly. And NICE, when they reviewed this application, actually explicitly modeled as a scenario analysis the impact of the FOCUSON program to the cost effectiveness of this strategy. And as Klaus mentioned, this slightly increased the cost effectiveness ratio, but still it remained well below this 20,000 pounds per QALY reference point. This is shown in the first column of data, where the base case estimate for the ICER increases from around 10,000 pounds per quality gained into the 12 to 14,000 pound per quality range under two different pricing models. One where it's an annual fee, 187 pounds per patient per year for the FOCUSON service, and the other where it's a one-time fee essentially for the life of the device, which is expected to be at least 3 years in most patients. Well, at this point, we want to bring in the third participant in our webinar today, Dr. Paul Guyler, and he's going to talk about sort of the nuts and bolts of how he has used this technology in his practice at the Southend University Hospital in Essex. So Dr. Guyler, I'll turn it over to you.
So, yeah, thank you very much. Really was going to speak about how we developed using these monitors within our practice. It's been very much a joint team effort between the stroke team and the cardiology team. And really it was developed, our stroke department's got a very strong research ethic, and it was involved in the Navigate ESUS trial, which was one of the ESUS trials. And as you're probably aware, embolic strokes of undetermined source represent about 20% of ischemic strokes. And there's been, there was a plan to work out with these trials, given the efficacy of anticoagulation in atrial fibrillation, whether anticoagulating these patients would reduce the risk of recurrent ischemic stroke. And so we've been very involved in this trial, and after about 7,000 patients have been randomized to either anticoagulation or aspirin, the trial was terminated early. And that was because there was a lack of benefit on stroke risk. Patients who'd had anticoagulation didn't have a lower risk of stroke recurrence than those that had been on aspirin. And there was also a higher incidence of major bleeding in the anticoagulation group. So where that left us was we couldn't just anticoagulate all of these cryptogenic stroke patients, which we presumed had cardiac embolism. But what the trial also demonstrated is that these group of patients have a risk of stroke recurrence of around 5% per year with either treatment, which is a higher stroke recurrence rate. And given the findings you've just shown as all of the Crystal AF study, and the fact that there's going to be a subgroup of these patients with atrial fibrillation who will benefit from anticoagulation, this is where I went cap in hand to our friendly cardiology department and of consultants and physiologists. And we developed a fast track pathway together in order to try and implant these implantable loop recorders quickly once patients had been worked up, to try and pick out these patients that we could treat therefore with anticoagulation to reduce their recurrent strokes, rather than antiplatelets, which are the default and recommended treatment after these trials. So there were two main concerns, even with NICE to start with. One is always due to cost, and how many of these devices will you implant, and it will cost the hospital out of their budget. And the other is also with the amount of investigations that are needed and will need, particularly with COVID around, is how do we select groups of patients who would be a good group to start with. And so we've developed this fast track pathway for investigations with the cardiology team for cryptogenic stroke patients who've made a rapid neurological recovery. Either they've had minor strokes or TIAs with imaging evidence of ischemia, or they've had more severe strokes who've had thrombolysis or thrombectomy, and they've made a very good recovery. And in our pathway, those patients will undergo imaging to show that they've had a stroke which looks embolic rather than a small vessel disease lacunar infarct. They'll have further investigations to exclude other causes. So they'll have imaging to look for an atherosclerotic stenosis or occlusion, which could be a cause of the stroke. They'll have ECGs and at least 24 to 72 hours of telemetry looking for atrial fibrillation. And they'll have other investigations depending on their individual risk factors, looking to see if there's other causes we could find as a cause of their stroke, like arteritis or dissection, antiphospholipid syndrome, drug abuse, migraine vasospasm, a stroke workup, in other words. And the patients we then want to move forward into rapid inpatient investigations with our cardiologists are those patients, as long as we're going to anticoagulate them and they're going to benefit from that. So we would exclude people with active bleeding conditions or hepatic problems with the coagulopathy, or a very low creatinine clearance, or people with a low life expectancy. But the vast majority then will go on to have transthoracic echocardiography with our cardiac team. And if they're under 60, they'll also have agitated saline bubbles and cardiac maneuvers to look for patent frame Navali. And if there are any abnormal findings on these studies, our cardiology team will then review and decide if the patient requires any further investigations or anticoagulation at that point. Assuming that's not the case, when the patient is ready for discharge, we will arrange with our heart and chest clinic for them to be discharged with a 72-hour Holter monitor fitted. And that will then go directly back to our senior physiologist, who will review it. And if that tape doesn't show atrial fibrillation in any form, then at that point the patient will be recalled to be discussed and consented, and have the implantable loop recorder fitted. What would then happen is our cardiac physiology team will interrogate the data, have routine checks, and obviously then we see if they have atrial fibrillation as a cause for their stroke further down the line. When I was thinking about hints and tips for other people trying to develop this, I think the key thing that we found was to start the service small and build it up. Particularly, there are financial concerns around trusts, and also to reassure all the people involved in the investigations that it's not a big burden. It's also, and the other key thing is to choose a group of patients that everyone agrees would benefit most. So for these patients who've had devastating strokes which they've recovered on, or clearly have had imaging which the cardiologist can see is going to be embolic. And then we can build on that. Now our trust has now merged with other trusts in Essex. So now we've got a group of 1.2 million patients. And what we're looking to do now, we've got this group and it's shown to be safe and effective, that we can now aim to develop this service for all of the patients in this region. So I hope that's been helpful in giving you a whistle-stop tour on what sort of patients we did and how we developed it with our cardiology team. And I'll hand back to Alex, who I think will be opening the floor now for any questions for the speakers.
Thank you so much, Dr. Guyler. That was really great run through of everything that went into building your clinic. So throughout the session, we received a lot of questions, and we'll address as many of them as possible. So please do keep them coming. Let me go ahead and bring up the questions now. Sorry, I'm a little bit of technical error here. Okay, so Dr. Reynolds, we had one question come in on cost effectiveness. How is cost effectiveness different from cost savings?
Okay, important and fundamental question. So I think to answer it, I would have you try to take the perspective of the decision maker regarding payment. So the health system. So a health system has to make a decision. Are we going to provide reimbursement coverage for a new clinical strategy? So let's say the old strategy was strategy A and the new strategy is strategy B. If the aim is cost saving, then it's a very simple equation for the payer. They will always choose the option that is less costly, less expensive. So that is in contrast to our notion of cost effectiveness. You know, my mother always told me you get what you pay for in life. And so sometimes if you pay a little more, you get a little more. Now, all health systems have, at some point, financial constraints. And so there has to be some boundary set to say, well, we'll pay for things that are a good value, but if things are a very poor value, maybe not. So that's really the difference between cost effectiveness and cost saving. If something is cost saving, but also clinically superior, then fantastic. That's a win-win, right? I mean, that's a no-brainer that every health system should adopt that. In health economics, we call that a dominant strategy. But it's not necessary for a strategy to be cost-saving in order to be cost-effective. And cost effectiveness has to do, again, with how much wealth a health system has, how much resources a health system has to support the health of its population.
Thank you, Dr. Reynolds. So the next question is for you, Dr. Witte. The Reveal LINQ base ICER was a bit over 10,000 British pounds. How does this compare to other diagnostic tools in stroke or cardiac care?
That's a really good question. Of course, it's also a really important question because as Matt has described, every healthcare service has limitations. Even the most highly funded healthcare service in the world will end up running out of money if you let doctors run amok. And so what you need to do is make sure that what physicians and their teams do is not only clinically effective, but also good for society. And one of the things that I always teach my students, as I'm sure Matt teaches his residents, is that we do have a responsibility to make sure that not just the patient in front of us gets good care, but also the patients that come after them. And if we spend everything on one patient, we can't spend anything on some of the subsequent patients. So you're absolutely right, Alex. The cost effectiveness ratio, for example, has to be compared with other things. But what's sometimes quite useful is remember, of course, that a diagnostic tool is merely a diagnostic tool. It's how you use it and in whom you use it. So you can't really take it away from the pathway. A pathway where you take a patient with cryptogenic stroke and you pop in a loop recorder and you find atrial fibrillation and you anticoagulate them is highly cost effective. If you compare that to some of the other things that we do, hypertension therapy, hypercholesterolemia therapy, renal dialysis, cardiac transplantation, these are all highly, much more expensive in terms of cost effectiveness than implanting a loop recorder. In terms of doing this all with Holter monitors, for example, I can expand a little. If I have a moment, I can expand a little. There will be people who say, well, look, why don't I just pop on a patch for a couple of weeks and I'll maybe save the cost of the loop recorder in some patients, and maybe that'll make it all much more cost effective and I don't need to put the loop recorder into some people. Well, of course, what happens is you have to pop the patch onto 100 people. And of those, maybe 3 or 4 will have atrial fibrillation in the first month. and the other 96 will still go on to need a loop recorder. So what you've done is you've bought 96 loop recorders and 100 patches, or 100 long-term monitors. And that makes it much less cost effective than just putting the loop recorder in first. So I've kind of not answered the question completely, but you'd expect this to be about as cost effective as it gets for a new electronic-based diagnostic tool.
Thank you, Dr. Witte. So the next question is for Dr. Guyler. What were the primary challenges you faced when building an ESUS clinic, and how long did it take?
I think it's still ongoing. I think the biggest challenge is, firstly, is although something may be cost effective, you've still got to convince the people who have the budget to release you money to then implant these devices. So this is why it's best, I think, as part of a joint venture between the stroke team and the cardiology team, because you've got to find the patients, you've got to agree on which patients to put these devices in, and then build it from there. So part of it is the cost aspect, even if it's cost effective. Then it's about making sure that there are a large amount of investigations that need to be done to show that a stroke is an ESUS stroke or a cryptogenic stroke. There's brain imaging and arterial imaging and blood tests and cardiac echocardiograms. And all of these need to be done in a very timely manner. What we found, well, the reason for doing a fast track pathway is otherwise this ends up happening 6 weeks to 3 months down the line. And there will be a proportion of patients at that point who may have had a recurrent stroke that we could have prevented. So it's about making sure that we can get these investigations timely, which is even more important when beds are at a premium and with COVID around as well. And then making sure that we've got pathways afterwards that will pick up and treat whatever arrhythmias get picked up. So I think that's why I'd recommend, if people are starting it, is to start it with a group of patients and build it up, and very much have a team ethic of making sure that everybody is on board, because otherwise you'll only be as good as your weakest area of the pathway and it won't really work.
Thank you, Dr. Guyler. The next question is for Dr. Reynolds. So this is back to FOCUSON. How does a triaging service like FOCUSON add to cost effectiveness?
Yeah, well, I'm not sure the triage service really adds to cost effectiveness. I mean, in a certain sense, it's increasing costs, net costs, very slightly. But what's reassuring about that is that increased cost still, when evaluated independently by NICE, kept the strategy very, far below the threshold of what's considered cost effective. What I see as the real value of FOCUSON is easing the administrative burden for the providers. Now, that administrative burden is not very clearly incorporated into cost effectiveness analysis. It certainly is not incorporated at the local level. So, imagine, if you will, that you have a smaller hospital that sees stroke patients, that has the ability to have someone implant LINQ devices. It's very simple to do. At my hospital, all of our LINQs are put in by a nurse practitioner who works for us. But then imagine that hospital does not have a trained staff to review all of the downloads that come from the LINQs. So at a local level, it may not be cost effective for that specific institution to hire an extra person because there may not be sufficient volume for them to do that. This is an area where, FOCUSON, again, can ease that administrative burden at the local level for a small incremental cost. So from the health system perspective, the incremental cost effectiveness ratio is a little bit higher. But I think, depending on the circumstances of the local center. So I haven't worked for an NHS hospital, but I can tell you, even where I am, when we have growth in what we're doing, and we have to seek additional resources to support that growth, it can be challenging. When we say we need another full-time employee to work for our electrophysiology program, we have to jump through a lot of hoops, and it takes a while to make that happen. So I see FOCUSON again as improving the efficiency of setting this up at the local level.
Thank you, Dr. Reynolds. The next question is back to Dr. Witte. So we've actually had a couple of questions come through regarding now that this has been published, are adjustments made over time for the DAP? So, obviously you have things like inflation, but do they ever look back after they've published and do any updates to it? Is there expected to be any revisiting of this topic, or do they just hold this as a ratio going forward?
I think on balance, Alex, that is highly unlikely. The process of doing this is so complex and time difficult, time challenging, that it is unlikely that this particular DAP will get revisited. Of course, they revisit certain DAPs when large parts of the calculation change, but in general, it is unlikely that they'll revisit this. It is unlikely that the price of the device will go up. It is unlikely that the device will become shorter in terms of its monitoring. In fact, if anything, the price is likely to continue to be steady or maybe even go down, and the duration of monitoring provided is likely to be longer rather than shorter. All of these things, of course, would have a positive effect on the ICER. The only thing that would have a major negative effect on the ICER would be either the treatment that the diagnostic tool causes you to use, or that it becomes ineffective. And I don't think either of those things are likely to happen. So I doubt very much whether this particular guidance is going to be revisited. It is possible that if other devices come on the market, that there will be a challenge to the fact that at the moment it is only Reveal LINQ that has been assessed like this. But essentially, if these devices would need to show equivalence, at least with the diagnostic programs that exist in the LINQ Reveal device, and even doing that would be seen as a difficult series of modeling processes to then show clinical equivalence with the diagnostics. And then to take that a third stage to suggest that the response is the same, that's a very complex series of models, each of which has its difficulties. It might still happen that other manufacturers come along and say, well, we have equivalence with the Reveal LINQ. NICE will probably say, fine, thank you, but they're unlikely to do another full DAP.
Thank you, Dr. Witte. And then I have one more question for Dr. Guyler, and then we have a final question for everybody. So my question for Dr. Guyler, who within your clinic conducts patient education, and how do they explain the need for monitoring two patients who may be resistant to having an implant?
Yeah, it's an important question, and what we try and do with the patients all the way along their stroke pathway is we try and educate them and explain to them what's going on and what the cause of their stroke may be, because with understanding they're more likely to be compliant with their eventual medication. So the part of the discussion and part of the patient education will start on the stroke unit while the investigations are taking place. And when the patient is discharged with their 72-hour Holter monitor, they'll be aware that depending on that, they may be contacted by the physiologist in order to consider an implantable loop recorder. So it starts on the stroke unit, and then when the physiologists have had a look at the Holter monitor, they will then phone the patient, and they will have a further phone call to say they've received this request and go over the reasons for that. And then when the patient comes up for the actual implantation, again, it's done as part of the consent process. So really, there's multiple layers to when we bring in the patient education into these devices.
Thank you, Dr. Guyler. So this last question came in actually at the very beginning of the webinar, but I thought it was very timely. So I think just keeping the order going, start with Dr. Reynolds, and then if anybody else has any input, we'll leave the floor open. But do you think ICMs will need to be more widely implanted in the COVID era, what with everything and the impact of strokes that we're seeing? Dr. Reynolds, you're muted.
Yeah, my apologies. We couldn't get through the hour without that happening at least once, right? Yes, very interesting question. There's no doubt in my area, and we had an early peak of COVID in New England, where really March, April, May was when we saw the greatest number of cases. We still have patients, even though the hospitals are fully operational now, and in the community, the COVID cases are very low. We still have patients who are reluctant to come to the medical center, even for something as simple as an EKG. So we have been sending, for certain clinical scenarios, in lieu of EKGs, we've been sending patch monitors out to patients through the mail. But of course, patch monitors have real limitations in terms of how long they can be used. So that's, serving a purpose for us, for example, monitoring patients on antiarrhythmic drugs. But for this type of scenario, for patients with strokes where we, specifically cryptogenic strokes, where we have strong evidence that long-term electrocardiographic monitoring is valuable, I think this really, strengthens the idea. The ICM can be put in prior to hospital discharge at the completion of the workup. We frequently do that in our practice. And then the patients don't have to come back. It's a real value.
I don't know if Dr. Witte or Dr. Guyler have anything to add.
Nothing except that I agree entirely. And of course, the great thing about FOCUSON is that you can increase the volume significantly without having to worry about how you're going to manage that. So we transferred all our device patients within a period of weeks over to remote monitoring, and having additional input from the providers of something like FOCUSON really helped deal with that upsurge in data that we were getting.
Yeah, I think from a stroke consultant perspective, these are going to be very, very helpful to us. We see so many patients who need hyperacute treatment with large vessel occlusions, and who get better with normal carotid arteries, and you're thinking, where's the clot come from? We see pictures, we see various imaging with embolic events, and we're saying, have we found AF yet? And the problem we've got is with the trials is we can't just anticoagulate them all, because that doesn't seem to be in the overall best option. So at the moment, until now we've been doing various 3-day tapes, 7-day tapes, Vista monitors, trying to find this atrial fibrillation, whereas now we can use these monitors and get on with seeing other patients well. The monitors find the atrial fibrillation for us. So I think they're going to be hugely beneficial to stroke consultants.
Thank you, Dr. Guyler. All right, so that's all the time we have for today. We hope that you found this session both informative and engaging. I'd like to thank Radcliffe Cardiology for organizing the session. A reminder, this event can be viewed again on demand at radcliffecardiology.com. I would also like to thank our fantastic faculty today. Dr. Klaus Witte, Oh, you're muted, Dr. Witte.
Yeah, pleasure to participate, Alex. Thanks.
Dr. Matthew Reynolds.
Enjoyed the discussion. Thanks again for having me.
And Dr. Paul Guyler.
Yeah, thank you, Alex. Thanks for having me.
And I'd like to remind everyone that to fill in the feedback form that's below on the webpage if you have a moment. And then as one final note, in order to claim your CPD credits, we would like to ask that you email emma.matthews@medtronic.com requesting your CPD credits. Once she gets your email, she'll be able to provide those to CPD and you will receive your credits. Thank you all for joining us and good night.